Good afternoon and welcome to today's Data Science Roundtable event. I'd like to take a moment to introduce our guest, Dr. Courtney Balentine. He is a board-certified endocrine surgeon specializing in thyroid and parathyroid disease, adrenal disorders, abdominal hernias, and surgical care for older adults and veterans. He is an associate professor in the Department of Surgery at the University of Wisconsin School of Medicine and Public Health, where he also serves as executive director of WISER and director of data science. His research focuses on inguinal hernia surgery in older adults, perioperative communication, and improving outcomes for aging and veteran populations. He evaluates how minimally invasive and open surgical approaches impact cognitive outcomes, functional recovery, and long-term quality of care. His recent publications explore intraoperative artificial intelligence interventions, disparities in access to endocrine specialty care, and barriers to clinical trial participation. Through his leadership in surgical data science at Wisconsin, Dr. Balentine is advancing rigorous, patient-centered approaches to integrating analytics, implementation science, and AI into real-world surgical practice. Dr. Balentine, we're absolutely delighted to have you today. Over to you.
Thank you for inviting me, and thank you for the lovely introduction. Let me just screen share here. Okay, can everyone see the presenter view of the slides? Excellent. So again, thank you for inviting me to talk about some of our work related to intraoperative AI interventions. In particular, the intervention I'm talking about today is what's been called the operating room black box, and kind of putting that into context. So by way of disclosure, my research is currently supported by the NIA and AHRQ. The black box technology that I'm talking about is a product of Surgical Safeties Technologies. They're not involved in any way in the research or the funding of the research that we're doing into black box. And I also just kind of mentioned, I have never actually operated in a room with a black box in spite of doing research for it. So I was around for the implementation of it. I've talked to a lot of surgeons who have, but haven't actually done it myself yet. So probably if you're paying attention to the news lately, you've heard some version of the upcoming AI apocalypse, which reflects a lot of fear around potential for AI and also the potential for harm. So a lot of the conversations about, is AI going to take over the world? Is it going to replace all of our jobs? What can we actually do with it, to make ourselves better? And it kind of reflects the underlying tension between there's a lot of opportunity in AI-based interventions. So there's also a lot of potential for harm of a variety of different ways. And so we're trying to find ways to identify interventions that are effectively leveraging AI to help make our patients better, and also hopefully minimizing any downside risk from leveraging new technology. And when we talk about what people actually want from AI, there's often this almost utopian vision of, if we can just train a good enough model, we'll be able to solve all these complex problems that are outside the scope of human intelligence and human ability, so we can solve more complicated problems and do it faster. We're also imagining that we find ways to leverage the technology to do some of the work that we find tedious, would like to avoid. They could potentially be automated, which frees up more time for humans to have quality of life. And hope kind of springs eternal. This may or may not be something that everyone is familiar with, but if you're an obsessive AI follower like I am, you've probably heard of OpenClaw, which is this really cool open source technology that came out not too long ago that really sort of seemed to fulfill the promise of what AI can deliver, which is it acts as a coworker, answering emails for us, cleaning up our file structures, logging into websites, making reservations, ordering us food. All the things that we've been hoping for a very long time all of a sudden was there, and we could actually do it. But you may have also seen articles along these lines in which the head of AI security for Meta downloaded OpenClaw, used it, and then couldn't stop it from deleting all of her emails. So kind of highlights the perils, pitfalls, and potential for AI, and also highlights a theme I'm going to talk about quite a bit today in our research for the OR black box, which is there's often a significant mismatch between the ideal, what we're imagining AI will do for us, and the reality of what it delivers. And I'm going to try to focus a lot of the talk today on the practical, which is how this gap between what we think or want from AI and what we actually get can be a major barrier to implementation, and discussing potential strategies for addressing that so we can take advantage of the technology. Because for healthcare, there's almost an infinite range of applications that we can leverage large language models, machine learning, and other techniques to address, ranging from assessing surgical skills and creating plans for improvement, creating real-time surgical partners and coach, improving team performance and communication inside the OR to enhance safety and lead to better outcomes for patients, preventing never events like wrong site surgery. The list just goes on and on and on. So much potential, but to really leverage all this inside the OR, the main barrier is you have to have a scalable way to collect, harmonize, and process the massive amounts of intraoperative data while also respecting patient safety, HIPAA compliance, and other regulatory aspects of doing this. And that's where the Aura black box technology really comes into play. So, assuming everyone is kind of familiar with Aura black box in the airline industry, that's meant to capture when stuff goes wrong. So, if a plane crashes or hits something or blows up, the flight recorder or black box is preserved so we can reconstruct the events that happened that caused the problem and then try to troubleshoot and prevent it from happening again. And the operating room black box was really built with this model in mind. So you're looking at here an actual OR that incorporated the black box. And the only difference between the physical appearance of this operating room and a typical OR across the United States and across the rest of the world is this camera here. So this is the main physical element of the OR black box. There's a camera that is used to capture what's going on in the room. And so that camera and audio system will enable the black box system to process what everyone in the room is saying, to transcribe it in almost real time and use it to analyze team performance and to preserve privacy. It blurs out all that information, the actual faces, when it feeds it back to you so that you can watch what happens, listen what happens in the OR, but you can't actually tell who was there, who was doing what, although you know the surgeon says X and the scrub says Y. You don't know who that person is, so it preserves anonymity. It also captures what the surgeon is doing for laparoscopic and robotic surgery at present. It doesn't work so well for open surgery at the moment, although we're told that's something that's coming down the pipeline, but it does capture all the audio-visual data from the actual terminal used by the surgeons to perform laparoscopic and robotic surgery. The black box also captures all the anesthesia information on patient vital signs, temperature, medication use, etc. And if you buy the right package from the company, you can also connect that directly to the electronic health record. And so you can project between what happens in the operating room and post-operative issues, length of stay, complications, costs and charges, et cetera. So it's a great system for capturing all that data, putting it together, has a lot of potential benefit, but does it actually do anything useful? And to kind of understand some of the practical evidence supporting use of the black box, and to go back in time a little bit to start with one of my favorite papers. This is the original New England Journal paper by Atul Gawande and his team, showing that a surgical checklist, basically requiring people to go through steps to confirm you're doing the right thing for the right patient beforehand, can lead to significantly improved outcomes for patients. It's actually one of my favorite stories, not just because it's a cool intervention and there were all sorts of fun quirks and implementation, but this paper actually got rejected when it was initially submitted. So every time I get a paper rejection, I tell myself, don't feel that bad about it. It happened to this paper. It actually, kind of one of my favorite stories, it took some phone calls from the folks at Atul Gawande's institution directly appealing to the New England Journal to tell them not to be doofuses and to accept this paper. So it took a lot of work to get this paper published. Kind of makes me feel better when I struggle to publish things sometimes. So the OR Black Box was meant to build on this and represent some of the papers that kind of very briefly go through what has been done with the OR Black Box to demonstrate some potential clinical benefit to make it worth implementing. So this is one of the early papers that came out from Dr. Grancharov's group in Canada, where they looked at using the OR Black Box to create what they were calling a structured team debriefing using the black box as a way to help people improve processes and performance in the OR. And this is an actual picture of one of the report outputs from the OR Black Box, where it basically went through all the different steps of things that occurred during the surgery, and it tried to highlight particular problems or dangers, things that could be used for future correction or future training. And it generated this report for all of the cases. It's a really helpful tool. The residents and the attendings very much enjoyed using this as a way to structure feedback on what's going on in the OR and lead to quality improvement through surgeon performance. Follow-up study from the folks at UT Southwestern, led by my former chair, Dr. Herb Zay, and one of my mentees, Jenny Meyer, actually then tried to draw the line between using the OR black box to measure intraoperative quality as a predictor of postoperative outcomes. And what they did was a study looking at a little over 4,500 operations performed in OR black box rooms. And these are primarily gynecologic and urologic procedures, since they did a lot of robotic surgery at the time. And they looked at using the operating room black box to automatically predict the quality of the preoperative timeout, the safety checklist, and the postoperative debriefing where we met and at the end made sure we had the right specimens going to the right places and everything lined up from the preoperative plan. And they connected this to post-op mortality, length of stay, probability of ICU admission, and operative time. And one of the key findings from this paper was the quality score generated by the OR black box. And this is an automated process that required no human interaction. The quality score on the debriefing and checklist correlated pretty strongly with mortality. So as the quality score got better from left to right, the mortality of the patients during that hospitalization actually went down substantially. So it's kind of drawing that straight connection between using the OR black box to measure a process, provide feedback to the surgeons and the trainees, and that process itself was connected directly to measurable patient outcomes. Dr. Grancheroff and his team also did an initial study publishing basically the first year analysis of what they did with the operating room black box in Canada after they created it, implemented it, tried it out in various ways to affect surgical quality. First thing that they showed was basically that the OR black box data quality was sufficient to do assessments of skill evaluation. So they used the video feeds, fed it to actual trained human reviewers, and it was sufficient quality across their health system. They could categorize and identify the difference between attending performance, fellow performance, and resident performance on objective measures of intraoperative skill. But more importantly, from a process standpoint, they used the OR black box to change how their system performed, starting by identifying how many problems were occurring during the OR, how many distractions got in the way that could potentially be linked to complications. And if you're a little bit OCD like me, you'll note a couple of things that pop out. One of which was they found about 8% of cases, somebody from the surgical team who was performing the operation showed up after all of the safety checks had been completed. So not a huge number, 8%, so it's not like it's a massive thing, but you imagine about 8% of cases across your health system, somebody is cutting holes in the patient, taking things out, and they bypassed all of the things that would help them promote patient safety by knowing what they're doing, why they're doing it, making sure it's on the right person with the right stuff. So small percent, but potentially huge impact for risk of safety, having people who don't know what's going on necessarily being involved in the surgery. On a personal pet peeve level, they also quantified something that I think aggravates a lot of surgeons, which is how many people come in and out of the room during a case. So across 132 cases in their health system, they found that for the median case, basically the door opened and people came in and out of the room 42 times in relatively short procedures. So a lot of people in and out of the room, increasing the risk of infection, potentially distracting the surgical team. So it just sort of highlights the OR black box did a really nice job of identifying there are a lot of areas that could be targeted to improve performance by cutting down on distractions, eliminating things that contribute to patient safety. And more directly, they started categorizing the number of actual errors, both in team performance and in operative steps throughout the case. And it was a surprisingly high number, admittedly with a fairly liberal definition of what constitutes an error. But as a starting point for quality improvement, it's really important to know these are the mistakes that we're making most consistently in cases. And it creates targets for interventions to say, let's figure out how to stop doing the things that are most likely to lead to bad results for patients. So we painted a little bit of a picture about why the OR black box is potentially worth investing in. But it's so great, why isn't everyone doing it? This is where we get into the area of implementation and looking at how you bring a thing to a health system and how you implement it can affect whether you actually get a decent return on investment. And for folks who are more or less familiar with implementation science, there are a lot of reasons why it's important not just to study whether something worked, but to study how it was implemented and how it was delivered. So reasons this can be important. If you find yourself with a program and it works, meaning in an academic sense, there's a statistically significant or meaningful improvement in some outcome as a result of your program, how do you know it couldn't have worked a lot better if you change the implementation? So we know for sure that low fidelity, meaning if you have an intervention that has 5 steps and you're only actually delivering 4 of them consistently, or you're delivering all of them but to low degrees or missing other parts of it, you're likely to get less of a dose response effect. So even interventions that are effective could be a lot more effective if they're actually delivered as planned. We also know that boosting acceptance, so if people actually want to do the thing that you're doing, that tends to boost the effectiveness. So both low fidelity and low acceptance can lead to greatly diminished effectiveness, even with an intervention that appears superficially to be working pretty well. The flip side of that, another reason the implementation is particularly important, is if your program didn't work, and say you deliver some new intervention that you were absolutely sure was going to lead to better outcomes for patients, how do you know it failed because the program doesn't work, or if it was just because it wasn't implemented well? So a lot of studies can show a null result, not because the intervention it might have been ineffective, but because it wasn't implemented well. And if you had delivered the intervention as planned or a little bit more effectively, you could have seen a really notable effect. So on both sides, studies that work and studies that don't, looking at the implementation can really give you valuable information to figure out what to do next and how to interpret the study results. And so the team that did the Aura Black Box up in Canada started out doing a really nice, comprehensive implementation study, looking at how they delivered the program and the barriers that got in the way. And they used two major frameworks to do this. So implementation tends to be a lot about frameworks, and these folks use what's called the theoretical domains framework to study their implementation planning. So they use this framework to think about how they wanted to deliver the Aura Black Box, and they also use it to study how that pre-implementation planning went. So the TDF, or the theoretical domains framework, really breaks down behavior change into three big domains. Capability, can you actually do the thing? Opportunity, is the system set up to make it easy to do the thing? And then motivation, do you want to do the thing? And so it's a nice framework for thinking about how to change people's minds when you're bringing in a new program that folks are unfamiliar with. And they use this to understand their planning phase. They also use what's called the Consolidated Framework for Implementation Research, or the CFR, to evaluate the actual implementation itself after the planning phase. And again, the CFR breaks down the whole implementation process into several key domains. It looks at the innovation itself. Does it offer an advantage? Is it adaptable? How hard is it, or how complex is it to actually do, and how costly is it to deliver? They look at the outer setting, so the patient needs, peer pressure from competing hospital systems, the legal environment you're working in, and how that can influence implementation. It also forces you to study what's called the inner setting, which is the culture of the organization, how communication occurs, where the organization is at in terms of its readiness to accept new things, and the structural characteristics of the hospital or the health system, as well as the characteristics of the people involved and the various steps of the planning process. So using the CFR provides a very comprehensive framework for understanding how implementation works, where it might have gone wrong, and how it can be better. And each of the constructs that you see here can be linked to specific implementation interventions that are targeting these individual domains. So it makes a nice process for both understanding and intervening on different implementation elements. And so what they found in this initial institutional study was that some of the main facilitators of the intervention itself was they built it to be scalable. So they set it up as a pilot project. No one was forced to do it. Everyone knew you could kind of scale up or scale down depending on how well it worked. It helped that there were no other competitors at the time for this particular technology. They were the only game in town, which made it a little bit easier to sell. However, the intervention was also very costly, and it was very early on, so they didn't really have any evidence to show it was effective. So this was a lot of hope and aspiration, and a lot of money required to do it. And these were potentially significant barriers to actually getting the job done. At the same time, they looked at the inner and outer setting, meaning the institution itself and the legal environment and competitors, other hospitals in the area, and found important facilitators like at their institution, people strongly believed that patient safety was a priority, and this was oriented towards patient safety, so it made it a little bit of an easier sell. And of course, since the whole process was created at that institution, they had a lot of leadership engagement to make it work. However, this is an important point that kind of comes up a little bit more later. Even in Canada, where there are pretty strong protections around hospital systems and it's a government-run health system, there are a lot of concerns about legal issues around what exactly this Aura Black Box thing was doing, the type of data that it was capturing, whether it raised concerns for privacy around patient issues as well as for the physicians and other healthcare workers. And it ended up being a fairly substantial concern. So this was the first and prior to our work, the largest study looking at the implementation of the Aura Black Box. And we liked the study. We thought it was a really good start and kind of paved the way for the work that we were doing. However, we wanted to do a slightly different study looking at Aura Black Box. And it was originally going to be one large paper, but it became so large we couldn't actually put all the stuff into one paper. So we ended up splitting it. We wrote this paper looking at the expectations versus reality of the AI intervention. And we wrote a second paper that's a much more comprehensive domain by domain walkthrough using the CFR. And that's something we're kind of in the process of publishing right now. But the main gap we're trying to address with this was the first paper that was done looking at black box implementation was done at the place that created the black box with all the leadership team in place. And if you've ever tried to bring a new intervention to a healthcare setting, you'll know it's a lot easier to do it when you have home field advantage. If you have your entire team in one spot, everyone is pushing in the same direction, there's a lot of motivation supporting it. It's generally easier, not easy, but easier to get your intervention delivered successfully. But if you want to do it elsewhere, it's a lot harder. If you're not there 24/7, you're relying on other people to do a lot of the work that your team took over originally. There are a lot of additional failure points that don't exist when you're doing it at your institution. And so we wanted to do a study that addressed that problem and didn't just look at the place where it came from, but looked at newer adopters to identify additional problems. And so we knew that the reasons for success and the reasons for failure in implementation are highly variable and depending on the setting and the context of the institutions. So we thought it was important to study how those things vary if you want to address them. And so we thought we needed a really good multi-site implementation study to get enough information on black box to craft a good implementation strategy. And so to do this, we got together three very large academic centers that had all implemented the black box, crucially at different phases of that process and different levels of maturity. We interviewed 31 surgeons and 17 implementation leaders who were involved in bringing the OR black box to each of those sites. And we used the CIFR to organize the entire study from planning what questions to ask to actually asking the questions and then interpreting all the results afterwards and making sense of it. So by way of demographics, for the surgeons and the leadership, most of the surgeons were slightly on the younger side, aged 35 to 50. About 30 to 40% in both groups were in the 51 to 80 range. So we got a decent representation across the age range for surgeons and leaderships. Most of the participants were men, primarily white and non-Hispanic. And most of the folks were in practice for a decent period of time. About 70% were in practice for more than 5 years in both the groups. So what did we find? Four key themes that we really talked about in this particular paper, focusing on this idea of the gap between what people expected from the AI-based intervention and what they actually got. So first theme was people were surprised that the AI needed a lot of training before it was usable. Second one, they had a lot of difficulty accessing the data from the OR black box. So even though it was generating stuff, they had trouble getting it out in a usable form. There was a lack of academic deliverables, which is always important to academic surgeons. And also one of the main things that people were hoping to do, which is predicting post-operative complications and finding ways to prevent them, didn't pan out the way they expected. So I'll go through it theme by theme. So theme one, people had this very strong idea or impression coming into implementation that this was something that was going to work right out of the box. That the Aura black box, the AI portion of it was trained, ready to go, could get all the usable data out and put it into functional form quickly. What each site found was there was a lot more work that went in than they expected to actually training the models for their specific questions they wanted to answer, the context of their institutions. And it was far more, even though they knew some work was required, it was far more than they'd expected. So one of our surgeons told us, in an ideal world, this would all just be automated. So as soon as I'm done with the operation, I would get an automated email telling me, hey, this is what happened during the last 3 to 4 hours of your operation. These are some issues that maybe are there. This is what went well. And the person was very surprised that wasn't actually what was happening. And another person told us we thought that somehow it would magically know what we needed. I don't know why we thought that. And we could just say, take a look at this case here and find everything important. And then, of course, give it back to me. And we also had this quote, we had to do a lot of work to refine the data we were getting. We had to do a lot of work to ensure there was an understanding of what our principles were. We had to do a lot of helping them being Surgical Technologies, the company that makes our black box, understand how OR is run. So the data that we got back really did reflect our operations in particular. And I wish I had known more then about how much building still needed to be done with this product. So really kind of reflecting that gap between the amount of work people expected to put in to get usable data and what they actually had to put in. They also found to their frustration that the access to the data was very variable and often more limited than they expected. So what people were hoping or expecting was that the AI portion of the black box could rapidly summarize everything that happened in the OR, spit it back to you almost instantaneously so you could use it for immediate post-event QI. The reality at every site was there was a significant lag time to receiving the data. And that's because the company had to do a lot of processing of the data even after it arrived before the analysis could actually take place. And that lag time varied a lot depending on the volume of the company. And of course, as more institutions start to implement the black box, the longer this lag time starts to be. And so one of our leaders told us, our biggest challenge has been we have M&M every Wednesday. So we generally pick the cases on Thursday or Friday from the week before. And the problem with using the black box for M&M is that we've been unable to turn it around in a way we can utilize it for that next Wednesday. So I think we used it twice in our M&M. We've had to delay that presentation for a week in order to do it. So the biggest issue has just been turnaround and getting it into a format that we could use in the M&M setting. And I will say this was not a consistent theme. One of the institutions actually did a really nice job of implementing a conference that incorporated the black box data, and we'll talk about that in a little bit. But a lot of surgeons at each site still felt like the turnaround was kind of delayed to what they were expecting. The third theme was the black box data had a lot of promise, allegedly, for predicting and preventing post-op complications, but the reality was it didn't do a great job at this. So the expectation was black box could identify events that occurred in the OR, draw strong connections between post-op complications and other problems, and we could then target those things for quality improvement. However, it turned out to be very difficult. There weren't a whole lot of complications, and the ones that occurred weren't necessarily directly correlated to something that was done in the OR. So it was kind of a scaling problem. You needed a very large number of cases given a low complication rate to draw strong associations between a particular thing that happened in the OR and the outcome later, with the exception, of course, of when the video caught something obvious like, tearing tissue or ripping a duct. But other than that, the subtle things, there just wasn't enough power, at least in the early and middle phases of black box implementation, to make this whole predictive process feasible. And so one of the surgeons told us, I wanted to find it beneficial. I think I found it cool and I found it exciting. We could have that kind of the full data from our case. But I think I found myself desperately trying to find someone or something to do with it and not often finding something to actually do with it. I was always wanting to say, okay, we're going to find something that happened in the OR that caused a complication. The heart rate went down, the blood pressure was down first, that somebody, didn't react quick enough, or that maybe the team dynamics weren't right or something. But I wasn't able to find that for most cases. And this was a very consistent theme across all the hospitals, even the ones that actually liked the OR black box. And lastly, there was a lack of academic deliverables. So a lot of the surgeons who agreed to participate in bringing the OR black box to their institution did so because they thought it would help them write cool papers that could potentially be impactful and affect patient care. But there were a lot fewer publications and a lot more work to get that information than everyone expected. So as one of our academic surgeons told us, they didn't feel it was AI-ish enough. Our team didn't see any publications coming out of it, and this was a big barrier to implementation. Another surgeon actually cautioned us, I really cautioned the early attempt to create generalizable knowledge from these outside of the direct improvement of care. I think once people think that they're being recorded for research and that's the primary purpose, if the first thing they see out of this is not a policy change, they don't see the data at M&M, they see it in a publication or a journal, I think you're going to get a lot of backlash from that. And so this highlighted sort of a flip side danger where even if you were able to get publications out of this data, people felt weird about you're recording them, watching them, and then converting that into a paper that they maybe weren't authors on and weren't part of participating in. So it caused resentment not only because we weren't producing a lot of papers, but the ones that were being produced was actually stirring up angst among the teams and causing some issues. So how do we fix these things? I mean, there's a pretty clear gap between what people were thinking they were getting and what they actually got. So how do you fix it, get around it, and mitigate that to the extent that you're able to successfully implement programs like this? Well, the big take home for us was we got to put a lot of effort into preparing everyone for the realities of adapting, training, and working with AI models in new healthcare settings. This seems kind of obvious, but sort of the deeper point for us was even what seemed like very intensive efforts may not be sufficient. So at one of our sites, for example, the chair went around personally to every division meeting, talked about it at just about every departmental conference. There were reams and reams of emails. He met individually with surgeons throughout the department, all for the purpose of saying, here is the black box, here's what it does, here's where it's starting, here's what you can get out of it. Let me answer any questions that you have. So he really put on a full court press, had a lot of support for doing it, and yet still a significant portion of surgeons at that institution, if asked, said they had no idea what the black box was, had never seen it, never heard of it, had no idea what was going on, and were extremely scared by all the things that his presentations had already addressed if they would have listened to it or heard it. And it kind of highlighted for us that there's often a disconnect between what the leaders think they're communicating in terms of effectiveness and reaching the right people and what actually happens on the ground. And this cross cuts into a lot of the changes post COVID, where people would log into meetings to, technically check the box of attending departmental events, but would be doing other stuff. They'd have their camera off, they'd have their mic off, they'd be answering emails on Amazon, doing other things that were distracting them during departmental meetings that they wouldn't have done if they were in-person meetings. And so even though technically they should have been learning about the black box of these meetings, they weren't getting that information. So I think it really kind of highlighted for us the need to go above and beyond and think about how the remote workplace can affect dissemination of information, identify other strategies for making sure that everyone knows what they're supposed to know. It's also important to design conferences around the limitations of the black box. So I mentioned earlier that one of the institutions did a really nice job of not being stymied by the delays and turnover for the black box. And what they did was they set up a monthly instead of a weekly conference that incorporated data from the black box. And that gave plenty of time to turn stuff around. It wasn't an immediate, it happened on Monday, something bad occurred in the OR, and on Wednesday you talked about it. But over the previous month, the expectation was you would identify some cases where review of the audiovisual data was particularly impactful. And it could be a positive or negative, meaning they didn't just say, here's what went wrong. They'd use it to highlight examples where crazy stuff happened in the OR and the teams did really well to handle it. So it was a conference that everyone was expected to attend. We knew what type of data we were going to be using, and it allowed enough lag time to complete all the processing. So people got a lot out of that conference, and it helped them see the value of what the black box could do. Well, also this study and our other companion paper raised the question of scaling. So black box can be very expensive for an institution to deploy. And oftentimes in implementation, you talk about starting small and growing big because it cuts out on the cost, gives people a chance to adjust. And if it turns out to not be working, you can just stop doing it, cut your losses. Problem here is a lot of the benefits of the OR black box only become apparent when you do it at a large enough scale to see those benefits. And so if you stop doing that, if you do it at a small scale, then you might not see those benefits and it becomes a self-defeating process. So somewhere there's a happy balance between what you're trying to get out of the OR black box and how many ORs you need to actually deploy it in to get that benefit. And it's going to be different for every health system. And finally, it kind of highlighted to us that looking at traditional surgical outcomes through the lens of the black box, meaning morbidity, mortality, length of stay, et cetera, may not be the optimal utilization at this point. However, there's a lot of unexplored stuff in the area of team performance and communication. So, how do you help teams communicate better in general? How do you help them handle stressful events in the OR to minimize any harm to the patients? How do you teach them to work better together as groups in the OR? There's not a lot of training about that in surgery, probably because there's not a lot of data. And so, if you pivot the expectations academically to say we're probably not in the first couple of years going to get any papers finding ways to reduce postoperative complications. But we could write a lot of papers about improving processes in the OR, improving communication, improving teamwork. Then you can satisfy that need for both practical and academic deliverables, while again balancing expectations against what the OR black box can actually deliver. And it takes a little bit of a change of a mindset to make that work. So, based on what we've done so far, our current grant is trying to continue this work forward in several ways. So first, we're using some of the OR black box data on what goes wrong and what goes right to develop augmented reality training programs that we're testing in a clinical trial to see if we can use black box data to create realistic simulations of what happens in the OR, and then use that as a tool to improve intraoperative safety and performance. We're also actively seeking out additional stakeholders. Our initial study that I showed you is purely surgeons and implementation leaders. That's not obviously the full perspective on people affected by the black box. So we're also trying to get opinions from operating room staff, including anesthesiologists, nurses, and others. We're bringing in legal experts to talk about the legal landscape around OR black box and what are the perils and pitfalls. And of course, we want to understand the patient perspective. We did an initial focus group as part of the original study to get the patient perspective on black box, and it was kind of illuminating and scary at the same time. So we're conducting additional focus groups to really expand that patient perspective to understand how they think about what we're doing with the black box now and what we could be doing with it down the road. And we're also potentially using it to train AI interoperative coaches that can offer real-time feedback on performance in the operating room. So thank you for listening to our black box work. I will stop screen sharing and I'm happy to answer any questions that you all have.
Wow, thank you, Dr. Balentine, so much. That was fascinating. Um, I've got a couple of questions, but I just want to see if there's any questions from the audience, first and foremost. If you just want to come off mute and ask away, we can do it like that. Okay, doesn't
Oh,
seem like
I
there's.
have a,
Oh,
I
hang
have a
on.
question. Yes.
Yes.
Hi, it's Hillary. I'm curious, what are some of the things that you are happy you did to set yourself up for success, in the beginning? And are there things that you wish you would have done differently?
Setting up for success in terms of what exactly?
Success in terms of so many, I guess, like so many different perspectives on like this within the operating room and different research perspectives, different papers that came out of this, the implementation of it, and how it was received.
Sure. So, I mean, I think I would like to say there was this really nicely planned stepwise process from where we started to where we ended up. That would be a total fabrication if I said that. So, the whole process actually started out by pure happenstance. So, way back when, 2016, uh, I had just got my first K award funded, and part of the K award training plan was getting some training in qualitative and mixed methods. Right. So I had signed up for this course on qualitative and mixed methods, and on the list of the catalog, there was this thing I'd never heard of before called implementation science that showed up in a couple of the seminars by this really fantastic scientist out in California named Allison Hamilton. And I sat there in the room and she just started talking about what implementation science was, why it was important, how you could leverage it. And I think as a surgeon, it just resonated with every like practical bone in my body saying, yeah, it kind of actually is important to know how to do stuff systematically, make sense of it, deliver the program as you want to and not as you think it ought to be, and navigating that sort of line between I have this cool idea and I want people to do it versus a lot of people don't want to do it just because you think it's a cool idea. And so that sort of started this entire 7 year journey of learning more about implementation. And then, again, I was trying to set up a research program around implementation science when I moved to Dallas, UT Southwestern, which is also unplanned. So I moved because I got married and there was no job for my wife in the place that I was working. And so kind of uprooted everything, took everything south and tried to start over. I happened to be trying to do implementation in a place that didn't do implementation, but I got lucky. So they hired a new chair who I met with him. I talked a little bit about implementation science and his eyes just kind of lit up and he's like, tell me more about that. I want to hear about that. And he also happened to be a huge advocate for the OR black box. I've been thinking about it for a long time. And then again, pure happenstance, there was another researcher down the road who was one of the world's leading experts in augmented reality and intraoperative simulation, leveraging NLP and other stuff to improve performance. And he didn't like the contract he was getting offered, came knocking on the door on the street, and the chair said, you two should talk. And so that's how this entire grant and project came about. So it had nothing to do with where I saw it going over time. And somewhere buried in my OneDrive is this 10-year research plan that I put together when I started my first job. And the current status of all this bears absolutely no resemblance to that whatsoever. It's not even the same topic area. So I think it was just kind of a fortunate convergence of events that happened to, I tripped and fell several times in the same direction and landed in a good spot. And that's how it got me to this place. Does that kind of answer your question?
Yeah, it does. Thank you so much. I appreciate it.
Dr. Ballantyne, I'd like to ask a question related to the last slide that you shared from your deck.
Yeah.
I'm really curious about the augmented reality training program.
Yeah.
I used to work at Meta. I've just seen obviously how their AR program, their metaverse, has just all been
Mhm.
shelved, and
Yeah.
they're now sort of obviously pivoting really hard towards AI. Um, I'm curious what you're looking to do with that program, and how it connects to this existing piece of work.
Yeah, so my partner, Dr. Sankaran Iron, who's currently at UT Southwestern in Dallas, um, had done a lot of work with basically training different types of models to understand what's going on in the OR. And his original focus had been, how do you create realistic practice scenarios for surgeons to learn how to do operations? And he was making pretty good headway along those lines, but he hadn't really thought about the communication piece. Right. So a lot of things that happen in the OR around safety are supposed to be very standardized processes to prevent bad stuff from happening. But if you actually look at the performance on those processes, there's an incredible amount of variation that gets in the way of all the good stuff that these safety checks will do for us. And so we kind of pivoted a little bit and said, okay, we want to figure out realistic scenarios where deviations from the best safety practices occur. How do we get that? Well, we got to have a whole bunch of videos and transcripts of things that happen in the OR at scale to identify the things that go wrong because it's a relatively smaller number of cases. And so this created an opportunity to pull all that information and directly review the videos from thousands of cases as opposed to like the typical scenario where someone does a research study, right? They're interested in assessing intraoperative team communication. They've got kind of a limited budget. They're probably going to put these video or recorders in a few ORs. They maybe capture a few dozen cases and try to draw inference from that, which is great. It works, but it doesn't scale. And so all of a sudden, we had the opportunity to review thousands of intraoperative conversations and events and really kind of built a taxonomy of, all right, what does it look like when it goes right and what does it look like when it goes wrong, and what are the trigger points that then take you down the right path versus the wrong path. And so we took that as like the basic learning points, and so he built the simulations around those points. But the question was, how do you get that out to people? Right, so if you ever tried to get education out to OR staff, it's like herding hamsters away from food. It's almost impossible because they don't have the time to do it. They're not interested. They do their in-services. Everybody feels like I'm doing this thing perfectly. There can't possibly be any flaws in my use of the checklist. It's got to be the schmuck next door that's causing the problems. And so there's a lack of interest, a lack of time, lack of knowledge, and a lack of motivation. How do you get around that? Well, the solution that he came up with was, okay, we could take them to a sim lab, but that's a giant pain. They have to physically leave the location that they're at because nobody has a sim lab in the OR. It takes up valuable space. It's always someplace else that's harder to get to. You can't bring this massive equipment like the simulators that we use in the OR in. So how do we get it to be portable, scalable, easy, transportable, and relatively inexpensive? And the solution was augmented reality instead of pure virtual reality or simulation. So we got a hold of the glasses. I forget the company that he used to get them. But basically, anybody in the OR can grab the headset, put it on. It pops them into an immersive experience. There's no weirdness. It really is driven by, it reacts to what you say. When you move your hands in the simulation, it actually has the real effect in the real world. You can answer all the questions by pointing and touching and saying. So it's a very convenient, very easy interface for people to use and gave us the chance to address, hopefully, all those problems that were laid out before. So we're at the point where we've actually like built the stuff. We haven't pivoted to doing the testing of the stuff yet, but that's the next step in the grant, basically getting that part done to show that we're actually having an effect and moving the dial.
Wow. Um, Fascinating. Thank you. Thank you for answering that question. Are there any other questions, folks, from the audience?
Yeah, I'll jump in and ask. When you think about all that you guys collectively have learned from this, long and incredible piece of effort to get these things installed, um, if do you think that the next thing that comes into the operating room is going to be easier or harder to get in based on this experience that you've had?
I don't know. So you would hope that some of this paves the way. And I should say, put it in perspective, the black box is not the only system now that's being used to capture information. There are a lot of places started installing videos. Stanford, in particular, and Dr. Carla Pugh does a lot of this, and like using audiovisual feedback from the OR to develop teaching systems to improve performance by trainees and by surgeons. But what I think the big hurdle coming up, and this is the part that makes me say I don't know the answer to the question really, is the legal environment around this is unsettled. So the big question, I think, from an external legal standpoint, not an internal, like I'm worried that this data might be used this way versus that way kind of thing, but the biggest external legal pressure is at some point there's going to be a complication, intraoperative or postoperative, that's video is there, audio is there. You may not see somebody like stabbing the pancreas, but you're going to have a procedure and there's going to be a complication after that procedure. And somebody is going to sue. And when they sue and find out that there's an audio-visual recording of what happened in the OR, they're going to want to see it. And that's really where the dookie hits the fan. So the question becomes, is this categorized as protected information for the purpose of quality improvement, like an M&M conference? Or is it categorized as patient discoverable information, which is no different from stuff you chart? Because we have, in the charts now, if you guys use Epic, you can snap a picture or a video, put it in the chart for reference and review. So which category does it fall in? I know which one all the institutions that have implemented the black box want it to fall into. And I know what category the company that makes it wants it to fall into, but it hasn't been tested in the courts yet. And part of the problem is to get an answer to the question, it's going to be up to each state and the federal government for the federal institution. So we're going to have 50 lawsuits in 50 states to settle state case law. And somebody's going to have to sue a government institution to settle the federal case law. So essentially 51 separate courts are going to have to go through this and figure out what's the right answer. And a few years ago, I would have felt a lot more confident saying this is clearly quality improvement, process improvement, protected just like M&M worries. But there was actually a recent case 2 or 3 years ago where the contents of an M&M became discoverable. And so all that case law is up for grabs now too. So when I say I don't know, because I think there might be some momentum, but I suspect it's going to stall the first time the lawsuit comes out until it's settled.
So hypothetically, if there was a federal 50-state piece of arguably robust legal protection for patient safety evaluation, it seems like that would be an important thing to pursue in your view.
Yeah, I think it would lend a lot of clarity. Whether you like the answer or not, there would be at least an answer depending on where you're at. And that would, I think, make it a lot easier for people to say, yep, totally worth the investment, or not loving that.
Yeah. Yeah. I think the other question is, our team and a number of folks on this call think a lot about a part of what you talked about, right? Which is, how do we design effective and impactful analytics? How do we make data available? How do we conduct science and research? How do we support researchers? And we maybe have less of our time spent on the implementation science side of this intervention. And as we go down this path, we continue to realize that that is increasingly important to do.
Sure.
For these kinds of digital interventions. I'm curious if you could design, let's say, the rollout continuous monitoring and other pieces of this effectively. How would you have done this differently? for these analytics and these interventions, given that like you can't make the AI omnipotent and it may require some training, although of course there could be ways to address that, we think.
Yeah, I mean, so I think there are several pieces that stand out for comparing and contrasting. Well, for example, one of our institutions actually de-implemented our black box. So we got to see how that process unfolded in real time and contrast it with a place that has gone gangbusters, and the third place has kind of held steady and not really expanded too much. And so we got to compare and contrast a little bit and take some of those lessons. So I think some of the big pieces were just around really, really, really focusing on the communication of what it's used for, what it's not used for, what it can do, what it can't do, and when it can do it, while creating this sort of environment that was open to this type of feedback. And I'll say we can't get into too many details because the other paper still hasn't gotten published yet, but part of what we found is a little bit disconnect sometimes between the way people have typically approached M&M conferences and the way it makes sense to approach it in a world where we have interventions that can show us everything that happened. So like, for me, it kind of strikes home during residency. I remember this case where got presented, there was a complication, a faculty got up, got in the crossfire, and everyone was asking, well, did you do this? Did you do that? Could this have happened? And it was always like, no, 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 everything was according to plan, blah, blah, blah. And one of my classmates was the chief resident in the case. And afterwards, she was like, yeah, that definitely wasn't true. This is what actually happened. Right. And so it was a huge disconnect between the lesson the audience was given and what actually happened. Now, with this technology, it would have been point and click. You could have gone back through and said, yeah, 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 you were in fact dragging this a lot harder than you thought you were, and there was the rip. And that's why there was a complication afterwards. So I think in a world where you have the ability to objectively look back at what happened, you have to change the culture a little bit about how you use that information and how you support the surgeons who didn't think they'd done anything wrong, but did.
Yeah, I know exactly what you're talking about. So my last M&M as a chief that I presented, I did a video M&M. And I think people were horrified. I think they were very happy to see me leaving 3 days later. But I think for the particular case, or for many of our cases, I was interesting actually, we were talking about this as a team the other day, and I was reflecting on this. Actually, it's not just how we talk about things, but it's actually what we talk about. We very seldom in M&M actually seldom present technical points for improvement. It's very commonly, oh, you didn't order this test on time, failure to timely diagnose, failure to take back to the operating room. Those are like the two big ones. But to the point of, I think one of the studies that you showed that had 100% error rate, or of error and event rate, right? I mean, I believe that, right? Like in some very bizarre sense of those words, like there's an opportunity for improvement in probably every single case we do. How do you think we get ready for that? Do you think that that's like at the level of the college, at the level of the board? Do you think that's at the level of the institution, the department, a tiny group across specialty society that says like the endocrine surgeons, or we're going to we're going to stand up here and we're going to talk about parathyroids, and we're going to talk about, calcium, and we're going to say, look, we're going to figure this out for ourselves. Like, how do we proceed?
I think it has to be a collective motion, because otherwise it becomes like whack-a-mole. If you're the first one to stick your head up, you're the one who's going to get smacked the hardest first, right? So I think it has to start with everybody who's doing surgery who says, hey, we'd really like to have good, objective, insofar as it's possible, undebatable data of this is what happened during the OR. And you can argue about whether this or that could have been done differently, but we start with a common set of facts and saying, this is what happened. How do we get better? So I think that has to be a group effort, and it has to be focused on not just like identifying specific areas for improvement. So it's not that every case becomes, here's what we could have done better, but it's also using this as an opportunity to highlight the positives. So if a team does particularly well Like, for example, one of the institutions was really good about flagging both cases that were outliers taking too long relative to what was expected, and those that were going a lot faster than expected, and then looking back at the cases that were better than the expected performance and saying, okay, what happened here? Was it the surgeon performance doing X, Y, or Z? Was it the team that did a better job of setting up this or that, and so on? And so it became a cultural change from let's talk about what we screwed up so we can do better to talking more about how does the process become better using positive and negative examples to show that. And I think one of the really, really key moves that was probably a good selling point at one of the institutions was the very first case that got discussed. The chair had actually set it up so it was discussion of his screw up. And he's like, okay, here's what happened in the OR. I did a crap job here at communicating with the team. I lost my cool a little bit. I was raising my voice to people. I was, yelling contradictory things to different people. And it's like here, here, and here, I could have done better. And then contrasted it with a case that did really well. And I think that willingness to say, I'm the person in charge, but I can still find positive and negative examples to do a better job for myself set a good tone. So as a first exercise and application of OR black box data, that was fantastic, both from a practical and an implementation standpoint.
Okay. Dr. Balentine, we're at time for the external part of this session.